Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, a neurocritical care masterclass. This is a long one. I think it goes over an hour, so just be prepared for that. Maybe listen in segments. It is actually a grand rounds we did here at Stony Brook with Neha, who will be joining the EMCrit team, and you will be excited by that after you listen to this podcast. So I do the introduction in just a second. You'll know who I'm talking about, but I think it's kind of great. We had a great time, many questions answered, and I think you will enjoy. Go to the show notes for more information on everything you're hearing. And with that, let's get right to the podcast. All right, let's get started. So welcome to Critical Care Grand Rounds. And this is a virtual Grand Rounds. Makes it a little tougher. We would have loved to have our speaker in person, but this is the next best thing. We have Neha Dangayach. Is that better?
That is much better.
Okay. Who is the co-director of the Neurocritical Care Unit in the Mount Sinai system. She is a neurologist and neurointensivist. She's the director of the NEMAT service through the Mount Sinai system, which you'll hear about shortly. And I've known her for years as someone amazing at Mount Sinai, someone who is on the pulse of cutting-edge evidence, who is involved in social media, and therefore is actually getting things before the 10-year dissemination cycle when they get to textbooks and online. She is a true intensivist first, which is the way you want your neurointensivist to be. And she's just completed a stint of running a COVID ICU. So in addition to all the neuro emergencies, she now has dealt with COVID critical care extensively. If she was in person, we'd do a PowerPoint presentation. As you guys know, I don't think those work on Zoom. So what we're going to do is a Q&A. And the first topic we're going to talk about is what NEMAT is, and go into that a little bit. And then we'll go into some sexy clinical neuro emergencies and neurocritical care. So thank you so much for joining us, Neha.
Thank you so much for that wonderful introduction. And if I can start with what neuroemergencies, our NEMAT program, the Neuroemergencies Management and Transfers program is, I'll give you a little snapshot on Mount Sinai's approach to neuroemergencies in a large urban health system, and some of the challenges we've experienced and some of the collaborations we established. So our approach to neuroemergencies is to ensure that the right patient gets the right care at the right time every single time. And to make that effective, where we've deployed this multi-hub, multi-spoke model, specifically for neuroemergencies like stroke and TBI, for status epilepticus, etc. So this has taken tremendous amount of coordination with our ED colleagues, radiology, housekeeping, throughput, our command center, which is like our transfer center and throughput combined, that helps move patients throughout this health system. And in 2017, we had transferred about 1,000 or so neuroemergencies. And since then, every single year, we've been doing about 1,000 neuroemergencies. One of our biggest goals has been to reduce the time to transfer for these inter-hospital transfers. And how do we do this in the safest possible way? So educating folks who are on the front lines to help them resuscitate patients appropriately, so we're not playing catch up by the time this patient is transferred to a particular site for definitive treatments, has been very, very effective. If there are specific questions about the program, I'd be happy to answer those. In COVID-19, we pivoted towards only doing life rescue transfers. As you can imagine, all our ICUs were under tremendous amount of stress. We were doubling up beds in our existing ICUs. So what we tried to do was really try to bring in only life rescue transfers. But despite that, the total number of transfers, if we compare the number of transfers sort of in that pre-COVID period, so January to March 15th, and then March 15th to April 30th, for the last 3 years, we see that the total number of transfers remained more or less around 350 or so. In fact, from 2018 to 2020, comparing the same sort of pre-COVID and post-COVID periods, we found that there was an uptick in the total number of stroke transfers. We had a little over 120 stroke transfers in this period of time. And in terms of our time to transfer, so what I find very heartening, so all that hard work to ensure that you build a system that works irrespective of pandemic, irrespective of a massive crisis, our time to transfer for life rescues remained the same. There was an uptick by only a few minutes, but we were able to keep our life rescue transfers, at our standard of care.
All right. So now I'm gonna grill you some questions on this because I find this fascinating, and it's gonna be relevant to all the residents, regardless of whether you go to an acceptance center, the hub, or you're at a smaller place where you're going to be doing the transfers. You need to know who to transfer and how to do it safely. So let's go through this a little bit. Before I start with the questions, if you folks have questions, put them in the chat. That's the easiest way, and then I will pose them to Neha. Now, the first question I want to ask, because it's a question on everyone's mind, is which ischemic strokes actually need transfer and which ones could stay at an outside center? So what do you think about that?
That's a fantastic question. So when we look at the landscape of elbow treatment throughout, since 2015, with several randomized controlled clinical trials, and then more specifically looking at this tissue clock with diffuse 3 and DAWN, specifically thinking about whether your center has the imaging capabilities to help us appropriately select a patient who's going to be eligible for thrombectomy or not. I think that's number one. For Mount Sinai, we rolled out this CT head, CTA head and neck protocol for every stroke subtype. So whether you were suspecting somebody had an ischemic stroke or hemorrhagic stroke, it doesn't matter. As long as you're suspecting a stroke, get that CT head and CTA. Unfortunately, what we're not able to do at the present moment is do CT perfusion imaging with high fidelity at various primary stroke centers, or even at some referral stroke center sites. So at thrombectomy capable sites and at comprehensive stroke centers, having those imaging modalities in place. So oftentimes, we recently wrote a paper on what are the reasons why somebody is not going to be eligible for thrombectomy after undergoing a transfer. And we found this to be one of the problems. If you cannot get CT perfusion imaging at a primary stroke center, then sometimes you're transferring patients who might not actually have, they might actually have a match defect. So by the time they come to you, either their penumbra deteriorated during that inter-hospital transfer process, or they never had a penumbra to start out with. So that's one kind of problem. Another kind of, go ahead.
No, please continue.
Another kind of problem is when there are those patients, and I think these are more difficult to tease out, patients who come in with a lower stroke scale. So patients who have a stroke scale that's about 2 or 3, but on their CTA, you see this ICA occlusion. That's the kind of patient who's going to get into big trouble because they are really dependent on their collaterals. So whether to acutely intervene upon that ICA occlusion, is this truly an acute ICA occlusion, or is this an acute on chronic, an unstable plaque? Are you going to stent this patient or not? That's the kind of patient you really need to watch very, very carefully. So our recommendation to our sites right now is, if you're seeing that and your patient's exam is really good, that's actually the patient you should be watching even more closely, and transfer that patient to a center that's able to perform Q1 hour neuro checks and have that trigger. When is that patient going to go to angio?
I have 2 questions, and you could take them in whichever order you want. The first one is, you obviously, as part of your NEMAT system, have created the ability to have easy access to the imaging. Let's pretend you are now taking from a center that has no connection to you folks. They're going to have to make a CD. They're going to have to burn a disc. We don't know if it'll actually happen or not. Should those people just transfer the patient and then you get the CTA and perfusion upon arrival based on some clinical scoring of the risk of LVO? Or do you still want the CTA done over there? And then the second question is, we've talked about transferring for LVO, large vessel occlusion. That makes total sense. What centers would you say transfer for any strokes, because you don't think the stroke care is going to be as good as at the hub?
So both very good questions. So let me tackle the first question. So specifically with respect to imaging, we're parallel processing. So when we're asking, we have the luxury of having one more platform, an added sort of safety net. We're using Viz AI, which is this artificial intelligence platform that's going to trigger an alert to all the experts. So if you're a stroke neurologist on call, endovascular subspecialist on call, etc. So everybody who's on call for taking care of patients who are potential thrombectomy candidates will get this alert. And when you get the alert, you're also constructing this CT perfusion map So we're not necessarily waiting for radiology to call our frontline providers to let them know, hey, there is a patient with a potential large vessel occlusion in your ED. In fact, we will notify the ED once we've seen this on Viz AI, and also deploy an ambulance. Now, this system, obviously, I'm making it sound like it's been very easy to set up, but it's not. It's taken us months and years to actually perfect this, and we still run into problems. Now, for our affiliate hospitals, for instance, we have some affiliate hospitals whose PACS systems we do not have access to. So, as a quick and dirty method, what we've been doing, and this is something I also have been doing for other neuroemergencies. So, rest of our team will, also get these, ask for videos. We'll ask for videos of the scan, and this video to be sent to our work phones without taking the patient's name or any identifiers into account. So that really helps us identify whether somebody has a large vessel occlusion or not. Even if you've deployed the ambulance and the imaging hasn't happened, but it happens while your EMS crew is en route, you could still cancel the ambulance and that patient could stay there.
Let me interrupt you there, because that's brilliant. So you are now at this tiny little hospital. How do you advance the CT such that you and your neurosurgery colleagues get the images you actually want on that video? What are you doing? How are you just like waiting some arbitrary period of time and then hitting the down arrow? How do you get a good video to be available?
So what you essentially do is you pull up the imaging. You have one person scroll through the imaging, at every 1 to 2 seconds or so. Don't go through it too fast. And when you're trying to make the head CT video, you'll see in most imaging systems, you'll see like this axial CT head. Axial CT head will be the right image that we want to see to be able to quantify someone's aspect score. So we've been doing a lot of these aspect scores on the phone prior to our Viz AI platform being deployed. So we'll ask you to take a video. So one person can keep clicking, and the other person records the video, sends it via a smartphone. Then for the CTA, there are maximal intensity projections. So MIPS, CTA MIPS for axials, coronals, and sagittals. So as long as you can give us videos of 2 MIPS, the axials and the coronals, even if you don't have the sagittal, that's completely fine. CT perfusion, completely understandable. Most places don't have the capability of doing CT perfusion, and that's okay. We might choose to repeat someone's imaging based upon whether their exam has changed. So you got a certain exam before you initiated the transfer. And by the time the patient comes to you, to the accepting hospital, their exam has changed. So has the exam changed for the better or for the worse? If it has changed for the worse, then you want to identify, have they completed their stroke, or is this because of a hemodynamic instability and their collaterals needed a higher blood pressure? Now their blood pressure is lower. So what is the exact reason why? Or have they received TPA? Was it a drip and ship and now they've developed a hemorrhagic transformation? So we might choose to repeat certain aspects of the imaging or the whole set of imaging if the quality of imaging wasn't good. That's also possible.
All right. I'm going to bring up one of your slides because this was mind-blowing to me. Let's see if I could. All right, folks. Now, this actual slide is in the show notes, so you'll be able to take a look. But in essence, what we wanted to talk about is that if the patient has a life-threatening neuroemergency at an outside hospital, they want a time less than 30 minutes from call to the patient leaving that emergency department. And these are transfer times I could never even dream of in our system. So, and you'll hear subsequently they actually make it close to these times on a lot of the instances. So this is incredible. Go to the show notes, EMCrit.org, to see the slide. But in essence, for things like intractable ICP, large vessel occlusion, etc., these patients are getting out of the outside hospital from 30 minutes from the time of calling the mothership. This slide for your departure within is the coolest system I've seen because I've had plenty of life-threatening emergencies outside of neurocritical care that I want to be brought to my ED in less than 30 minutes, and I've never had it happen in anything less than 2 hours. So why don't you walk us through this slide and talk about how you actually got a transfer system that gets the patients out of the hospital and to you if they have life-threatening emergencies?
Awesome. So first and foremost, I should say that this was born out of the need to do exactly what you described. How often are we waiting for patients? Even after you initiate an inter-hospital transfer, you've got your cath lab activated and you're still waiting for the patient. So what are all those things that are preventing our frontline providers in the EDs from sending these patients to us as rapidly as possible? So the first thing we figured out was education, making sure that everybody was aware that there are certain types of cases where you really cannot wait, and to contact us via this central command center. So the command center works not just for neuroemergencies, but for all emergencies right now. So, or any inter-hospital transfer. And I should say not just emergencies. Like you can see on my slide, there's a level 3 where you might want to transfer a patient to an inpatient bed, not necessarily to your ED. But for life rescues and level 1s, and several level 2s as well, if there's no bed availability, that's not what you're going to wait for, but you're going to get everything else downstream activated. So to put something like this in place, there was a lot of buy-in from leadership. So thinking about a pull model rather than a push model, how can we ensure that every single patient gets the right level of care? The other cool thing that happened in 2013, we became a health system. And when you become a health system, it comes with its own sets of opportunities. So how do you convert any challenge into an opportunity, and how do you find partners at every level? And you don't need to have everything. So there are lots of different models. We could have chosen to become specifically for neuroemergency. We could have chosen to become like a hub and multi-spoke model. Instead of that, we chose to become a multi-hub and multi-spoke model to really leverage the strength of our different hospitals. As an example, there's an NYC MIST model slide that I had. It's a paper that was published a few years ago describing this model where our endovascular team goes out to 4 different sites. Now, comparing the NYC MIST model to actually transferring a patient over to a thrombectomy capable site or to a comprehensive stroke center, we found that you're shaving off more time. It's at least 30 minutes or so faster to get the endovascular specialist to a site where they can perform the thrombectomy. And that kind of model, plus this multi-hub, multi-spoke model, really helped us think about. Sometimes it's not the healthcare providers that are responsible for any sorts of delays or lack of recognition or knowledge, or none of that. It comes to capacity. Does your hospital or hospitals have the capacity? Is your ED on diversion or not? So how do you create a safety net for all of these different kinds of emergencies? Our chair of neurosurgery proposed this model for coming up with a time from call to departure within whatever period of time. This was extrapolated from the OR category. So when you're activating a category 1, category 2, there are very specific metrics that your anesthesiology team, that your surgical teams need to meet. So we just extrapolated that to our transfers. And then each subspecialty was asked to come up with, what do you think are the top few emergencies that you would want to categorize under each of these? And then we're longitudinally tracking massive amounts of data and seeing if this is actually something. These are numbers, this 30-minute, 60-minute, 4-hour mark. We came up with this, extrapolating information from OR categories, but are we actually built to meet those time metrics? And are these even realistic? So the more we're collecting data, the more we're learning on how to fine-tune some of these expectations. But if you don't start somewhere, how are you going to get anywhere?
So how realistic are they so far? Are you getting patients out in 30 minutes if they have these life rescue categories?
So, Scott, I actually have a slide on our life rescue transfer times. Slide number 39. This is for COVID. And let me pull up a previous slide. And you'll see, how challenging it is. So these are transfer times pre-COVID and post-COVID. So one of the first things you will notice about this slide is there are several transfers that do not have a transfer level assigned. So it tells us that, yes, you have a system in place, but it's not like everybody is necessarily identifying each case as a particular transfer level. So that's one very, very small problem. But we can absolutely address that to increase the fidelity of our data collection, to make it a better learning health system. And then when we look at the timestamps, so these timestamps are specifically from the time our command center gets notified to the time this patient arrives at the receiving hospital.
Oh, wow. So it's arrival, not even departure.
This is arrival. That's what I wanted to highlight. So what I'm showing you is from notification to arrival, which includes everything, includes all the notifications, all the calls back and forth, the throughput piece, all of it. So I think we're doing a pretty good job with the life rescues right now. And despite COVID, our life rescue times, as you can see highlighted, I mean, we're still doing pretty good, under 90 minutes from notification to arrival.
That's pretty impressive. Now, you have a set of protocols that make this all happen. Would you be willing to share those with us at some point?
Oh, absolutely. Right, I'd be happy to. Yeah.
So we'll disseminate those to the residents. It's something to build your own system with. Okay, folks, if you have questions about NEMAT and transfers, put them in the chat. But in the meantime, I wanted to move to some clinical questions. And the first topic is intracranial hemorrhage. And you mentioned scuba, you mentioned clot evacuation. Why don't you talk to us a little bit about what you folks are doing with that?
Okay, so like I was mentioning, how do you convert a challenge into an opportunity? So as our health system was growing in 2016, there were a couple of issues that we were constantly running into. Capacity creation. We have 2 neuro ICUs within the health system. And at that point in time, we had just about started thinking about what disease processes can Mount Sinai West become a hub for. And one of our neurosurgeons, who's now the director of our ICH program, Christopher Kellner, had also we'd been enrolling in this Apollo trial at that time for ICH, minimally invasive evacuation. So that entire ICH program was moved to Mount Sinai West, both for the hyperacute care and this minimally invasive clot evacuation paradigm, and also for their post-evacuation critical care, to make sure that no patients were languishing in PACUs. How do we make sure that you can seamlessly move from either it's from the ED to the angio suite, get the scuba procedure, and then move to the ICU for your post ICH evacuation care. And very careful selection of which patients are going to be a part of this protocol. And the more we've been doing it, now we have more than 200 patients that our team has performed these scuba procedures on. And we published, thank you so much. And we published several interim analyses now showing, this is specifically after MISTY. So when you think about MISTY 3, was it truly a negative trial or not? So at least our team's thought process is, for us, it was actually a very promising trial, because it showed that if the residual volume after evacuating a clot was less than 15 cc's, your patients will have a better outcome. So with better technology, and this is exactly what happened even in the thrombectomy world, you had some initial studies that didn't use devices, stent retrievers, that really became standard of care from 2015 onwards. And we didn't have great outcomes. And now that we have good devices, we're seeing good outcomes. So carefully selected patients with the right kind of technology, we can see better outcomes. So that's first, why is it called scuba specifically? So these patients are taken to an endovascular suite. There's a burr hole that's drilled. Then there's a catheter that's guided to the bottom of the cavity. Often Chris and his team are also doing an intracavitary ultrasound to examine the cavity. They're inserting cold saline after evacuating the clot to look for any other active bleeders as well. So it's literally like looking for any active bleeders underwater. So that's why scuba, and essentially you have a catheter that's going down. That's how the technique got its name.
And so who is the selection for this? Who is being evaluated?
So patients who have a premorbid modified Rankin of 2 or better. Age-wise, we're still we're not necessarily saying that patients who are older than 80 will not qualify. We're still going case by case, particularly if those patients have a good premorbid status. So in the first year or two of SCUBA, the patients were waiting for about 6 to 8 hours. You get a stability scan. You've got their CTA as part of their initial scan. Make sure they don't have a spot sign. But now, Chris and his team have also developed a technique for cauterizing active bleeders. So they're not necessarily waiting for a stability scan. And in terms of the hematoma, the NIH cutoff, so if somebody has a NIH of 8 or higher, those patients will be evaluated. The volume of the hematoma should be 15 cc's or greater to qualify for SCUBA. But patients who have a posterior fossa bleed, so specifically somebody who has a cerebellar hematoma, more than or equal 3, most people on this in the audience will know that 3 centimeters or more in any dimension, that patient should be evaluated for emergent surgical decompression, not minimally invasive clot evacuation. Similarly, for patients who have massive lobar hemorrhages, who are actively herniating, those patients are not going to be SCUBA candidates, but you're going to need to do open, not surgical evacuation of the hematoma, but a decompressive craniectomy.
Absolutely. Let's stick with ICH. We get a lot of questions about how we should be managing blood pressure. The literature keeps bouncing back and forth. We had some studies we were hoping it was going to show radical benefit to tight blood pressure control. They didn't really pan out. What is your practice right now for intracranial hemorrhage blood pressure?
I'm going to keep it very, very simple. We chose systolic blood pressure of less than 140. And why did we do that? So despite INTERACT-2 and ATAC-2, and specifically for ATAC-2, thinking about tighter blood pressure control, and within 7 days, those patients might have more AKI. But there's also plenty of data to suggest that if you control someone's blood pressure tighter, it's safe. Having said that, just yesterday, there was a secondary analysis from ATAC-2 by a really good group out of Yale to think about that paradigm, that time is brain. So they did a subgroup analysis for tightly controlling blood pressure within 2 hours of presentation, and they found it to be safe as well. And those patients can potentially have a better outcome. Now, having said that, let me talk a little bit about the practical advice about blood pressure management. So in all of these trials, it's not like every patient had an A-line in the ED. It's not like every patient is undergoing inter-hospital transfer with A-lines either. So being very specific about how often you want that blood pressure cuff to be cycled, because you don't want your patient to become hypotensive either, because you want to maintain cerebral perfusion. But at the same time, letting our ED physicians know, letting our ICU teams know that we want the blood pressure to be less than 140. And I'll talk a little bit about different medications, but cycle the cuff depending upon which medication you're using to target someone's blood pressure. For example, if you're going to use a Cardine drip, the onset of action is going to be in a couple of minutes or so. So make sure you're recycling the cuff to reach your target. Once you reach your target, that you're stable. And once you're stable, then you're at least cycling the cuff every 15 minutes or so till the patient reaches their destination. So I think that's important. And often it's hard to achieve those kinds of targets, particularly when patients are moving from one place to another. We found that not specifying the frequency of cycling the cuff, it sounds like such a simple thing, but not specifying that frequency does not set our patients up for success. The second thing that we discovered was, so we have various EMS crews that we work with, but for our critical care transport, we're mostly working with senior care. So what we discovered was they don't have antihypertensive drips besides nitroglycerin. So what we do now, we can, I don't need to belabor the point that we don't want to use an isolated venodilator in patients who have a suspected raised intracranial pressure. You want to use a more balanced agent. So we're normally going to recommend a calcium channel blocker drip like nicardipine or clevidipine. Clevidipine is available at several of our sites, but Cardine is more easily available, or a beta blocker drip like a labetalol drip. Esmolol is great for heart rate control, but not the best for blood pressure control. So whatever drip you're choosing, guiding the frontline team, letting them know if you're the ED provider taking care of this patient, make sure that you're cycling the cuff till you reach your target. Once your target is reached, then you're at least cycling the cuff every 15 minutes or so till this patient reaches their destination. So less than 140. And just to pivot from there, why less than 140 is an easy number for us to remember. For subarachnoid hemorrhage patients who have ruptured or suspected ruptured aneurysmal subarachnoid hemorrhage patients, we're also recommending systolic blood pressure goals of less than 140 till their aneurysm is secured. For patients who've had traumatic brain injury, we're also recommending blood pressure goals of less than 140 to ensure that there isn't a hematoma expansion. But we'll typically also give a lower goal that maintain the systolic blood pressure greater than 100 but less than 140.
You just mentioned something that if I had to make a list of the most misunderstood things in neurocritical care is one of them, which is the amount of hematoma expansion in an ICH. That is the difference between life and death. Well, I'll leave it to you. What is the amount on average of the difference between life and death and hematoma expansion in ICH?
In clinical trials, what's been counted as significant is about, when you're looking at these volumes, it's about 30% or so expansion. An easy thing to remember about ICH, about a third of these patients are going to have 30% of their hematomas expand in the first 3 hours. So what does this mean? This means that your opportunity to impact their longitudinal functional outcomes is tremendous in an emergency room. So making sure that their blood pressure is adequately controlled, that their coagulopathy is adequately reversed. Those are really life-saving, irrespective of what downstream definitive intervention they're going to undergo, whether it's a surgical or minimally invasive or a max medical therapy. I think that's very important to keep in mind.
Now, you just stated that in the more accurate way, but not in the more bold way that I get people to understand. Because when you think about how small the bleeds are to begin with, that small percentage expansion could be the difference of 10 cc's could be the difference between life and death on these patients with bleeds in exquisitely sensitive areas. Meaning, when you see a bleed and you're like, that's not so big, don't worry about it, I'll fix the BP over the next 5 hours or so, and I don't need to reverse this coagulopathy. That is a complete misunderstanding of how intracranial hemorrhage works. The difference between life and death could be an incredibly tiny volume of blood.
Absolutely. And you're spot on about where is this hemorrhage located? Plus, going back to, if you're suspecting a stroke, get that CTA. That's going to give you the ability to identify which patients are at an even higher risk of hematoma expansion. So by way of this spot sign. So essentially, this spot sign is very similar to anywhere else in the body that you're getting a CTA for to look for active extravasation. And the total number of spots as well has been correlated. Like if you have more than 2 spots, that's a higher risk of hematoma expansion. But the spot sign is well validated. And the other thing that CTA can also do is tell you what the potential underlying etiology is going to be. So yes, for spontaneous ICHs, hypertension is the number one cause. And it could be worsened by people who are on underlying antiplatelets, anticoagulants, etc., or they have hepatorenal dysfunction. But specifically for patients who have AVM, so arteriovenous malformations, and did the venous side of the AVM bleed, or did the arterial side bleed, or is there an associated aneurysm with that AVM that bled? So that can be the difference between life and death. Just recognizing what the underlying lesion is. Or let's think about this other rare form of stroke, this cerebral sinus venous thrombosis. Sure, you're seeing an ICH, but that ICH is because of venous stasis. So getting that vessel imaging the moment you're thinking about stroke is invaluable. That can really, really help figure out what the downstream treatment pathway should be. Is this a primary ICH? Is this a secondary ICH? Do I need to transfer this patient to a center that has endovascular, open cerebrovascular capabilities or not? I think that's important.
Let me hit you on a piece of that last answer, because we're always curious on this. Let's say a patient presents with a horrible headache, thunderclap headache, and so we're working them up for subarachnoid. We do our CT, we do our CT angiogram, and they didn't give us any of the buzzwords that made us think cerebral sinus thrombosis or cerebral venous thrombosis. Will the CTA pick it up, or does it need to be some form of venogram?
I think you have to specify. So in terms of how the CTAs are timed, so once you give the contrast bolus, it's timed for picking up the arterial phase. Often we'll also end up getting the venous phase because it wasn't timed properly. So you'll get both arterial and venous, but I think you have to specify. But if your patient doesn't give you all the buzzwords, but they are peripartum, or they have an underlying malignancy, or they've had diarrhea for a while and they just did not want to come to the hospital because they thought they'd get COVID-19. It should alert you that, and all for our health system, I know that all you have to do is specify in the in this comment box for radiology, please do a CT venogram. So at different centers it's different. You might need to specify or put in a separate order for a CT venogram. But that's one of those strokes which is harder to diagnose. And another quick pointer towards imaging, clues on imaging. So even if you don't have a story or you don't have like typical risk factors, if you end up seeing this high up cortical subarachnoid hyperdensity, now that hyperdensity could be blood or it could be something else, or somebody has come in with fever, neck stiffness, and you're thinking, oh, this is absolutely meningitis, and you scan their head because they have some focality, and you just done a non-con head CT, and you find that now they have some edema with some hemorrhage in the left temporal lobe. Now, could that be septic sinus venous thrombosis? So just looking at the imaging and thinking about the patient milieu will guide you on whether you need any additional imaging or not. Now, in busy emergency rooms, you can't keep sending a patient back and forth. So you should be calling for help at that point in time. The moment you're suspecting an acute stroke, irrespective of the subtype, make sure that you've already notified, your stroke team or neurology team, or if you're seeing blood in the head, then you're notifying your neurosurgery team so they can guide you as well on what additional imaging might help figure out what this patient has, or what should our next steps in treatment be.
Fantastic. Let's swing back to ICH. And now this is a non-traumatic ICH. Who are you giving seizure prophylaxis to, if anyone?
Nice, controversial question. So looking at all of literature and all the guidelines right now, there's no strong recommendation that can be made for seizure prophylaxis. So what are we doing? One of my neurointensivist colleagues, John Liang, says, in the absence of evidence, at least be consistent. So what we decided was anybody who has a lobar hemorrhage, irrespective of the underlying etiology, we're going to prophylax. We're using Keppra prophylaxis, and we'll do that for about 7 days or so. Now, for subarachnoid hemorrhage, we did change our internal protocol. For subarachnoid hemorrhage, we're prophylaxing patients. So if they are low-grade SAHs, we're only prophylaxing them for that 1 day before their aneurysm is secured. And we'll stop the prophylaxis. For high-grade SAH patients, so patients who have, our Hunt and Hess 3s that behave like 4s and 5s. So patients who are in a coma, patients who are stuporous, have hemiplegia, those patients will continue seizure prophylaxis for 7 days. If any patient has undergone a craniotomy, not scuba, not minimally invasive clot evacuation, but a craniotomy, then we will prophylax for 7 days.
All right, very good. Nicely skirting all the issues on that one. I love it. All right, let's talk about a more controversial topic. Let's talk about reversal of coagulopathy and platelet agents in ICH. Let's start off with coagulopathy. So we oftentimes, from some of our older neurosurgeons, hear, it's a tiny bleed, you don't need to reverse the Coumadin, which is against every bit of training I've had in neuroemergencies. What is your take on who should get reversal of, we'll start with Coumadin in ICH?
There's plenty of data, Scott, to say that you should reverse any, irrespective of the size. I know one of your residents had posted this question as well. Mm-hmm. Like, there's a small bleed and should you be reversing or not? So of course, like everything in medicine, you are going to weigh the risk benefit. You're going to explain this to the patient or their family as well, that, hey, there is a risk that this person is going to potentially develop, a DVT or PE or MI. You're just going to talk about the risks. But I think it's extremely important. And we know that even 30 minutes of delay in reversing Coumadin in a patient who has an ICH can really worsen their outcomes. So we know this. And there are very few things in in neurocritical care, where you know that there's a direct impact on outcome. So here, when you think about coagulopathy reversal, both for Coumadin, uh, I'm guessing you're going to ask me a question about NOACs as well.
Yep.
So I think it's important to first, we'll try to identify, so patients will roll into the ED without, they were found down. Now you don't have any family, you don't know, you don't have any prior medical records, you just don't know when was the last time they took their Coumadin, what is their INR. I can't wait for their INR to result when I'm seeing blood in the head. So what are you going to do? Depending upon what you find on your point of care ultrasound, for example, you found, they have heart failure with reduced ejection fraction, they've got an LV thrombus or whatever. So potentially, even if you don't have the history, what that underlying cause might have been for them to be on anticoagulation. Then weighing the risk benefit, depending upon the size of hemorrhage, the mechanism, when was this person last known normal, when did they last take this medication, then you go ahead and reverse.
Yeah. Are you guys doing a empiric dose of 4-factor PCC, or are you purely doing INR guided reversal?
So again, thinking about that time-based paradigm, we're not doing point of care INR testing, so we don't get our INRs back as fast as we would want them to. So often we'll at least start with 25 international units per kg, not wait for the INR. And if needed, then we'll give an additional dose. We'll follow that up with vitamin K. We're doing vitamin K 10 milligrams IV, and then we'll do two additional doses as well. We're not always rechecking the INR after giving K-Centra, but we found, and this is more anecdotal, this is not necessarily supported by what's reported in literature, but we found there are some patients who, despite getting the right dose of K-Centra, still have an elevated INR. But we're not redosing in those patients, and we'll just give them some additional FFP. On a case-by-case basis, again, because we don't have ROTEMs available as fast as we would want them to, or as widely as we would want them to help guide who needs more products. On a case-by-case basis, when we do have that result, or if someone's going to go to the OR, or they've come back from the OR and you see more, surgical site bleeding, then does this person need more reversal? So we've done that on occasion, but we'll give them additional FFP or cryo if their fibrinogen level is less than 150.
All right. Now you've already anticipated the next question, which is, what are you folks doing for DOACs, NOACs? Are you doing the FDA approved but very scant literature basis, or are you doing the more empiric 4-factor PCC?
We're doing 4-factor PCC. So we put in a lot of thought as a team on whether we wanted Andexanet on our formulary or not. And our consensus with neurocritical care, ED, our hematology team, neurosurgery, everybody, our stroke neurologists, everybody agreed that we did not think the literature on this supported us putting this 50,000 or so dose medication on our formulary. And the other bigger concern was, after 4 hours, that effect on 10A is actually going away. So are you then going to see a rebound increase in hemorrhages? Are you going to see a rebound increase in hematoma expansion? Although their study, Nexa-4, does not allude to rebleeding, etc., we were concerned about that. So we're doing 4-factor PCC, and depending upon the other concomitant issues, whether somebody has hepatorenal dysfunction or not. And if they do, then we'll also do a dose of DDAVP in addition.
Love it. I love it. Okay, now the really contentious one. Which patients, if any, are getting platelet reversal? And if you need to separate out aspirin versus Plavix, by all means, and certainly separate out your ones who are getting neurosurgical interventions versus the ones who are just being monitored without neurosurgical intervention.
So thinking about all those different populations, I'll first start with the easiest. So patients who are undergoing max medical therapy. For max medical therapy, we'll do, so our CT for all the different populations is we'll repeat a CT head 6 to 8 hours from the initial CT head. And if there's no hematoma expansion, we're not going to be giving platelets. DDAVP, again, there's more emerging literature on DDAVP. Some of the earlier studies just had very small numbers. We haven't seen any safety concerns with DDAVP. So we're going ahead and giving DDAVP 0.3 micrograms per kg, but not necessarily platelets. For patients who are going to undergo a surgical procedure, specifically if they have intraventricular hemorrhage and they need an EVD, It's again case by case, depending upon whether those patients have underlying hepatorenal dysfunction or not. What was the indication for why they were on single or dual antiplatelets? If they recently, particularly if they recently got a drug-eluting stent, then we're not going to give them platelets. We'll really be thoughtful about who should we be giving platelets to. And with respect to what Patch taught us, several of those patients had smaller hemorrhages. They were not necessarily undergoing neurosurgical procedures. So if someone's going to undergo a craniotomy, then we might end up giving them platelets, particularly in the OR.
Are you giving DDAVP to these patients? That new
Yes.
trial that was just published?
Yes, I would say DDAVP to all comers right now, unless somebody's hyponatremic. So you get their labs and they're hyponatremic, then we're not going to give them DDAVP. But if they're not hyponatremic, then yes, DDAVP 0.3 micrograms.
Oh, I'm so glad I asked that, because that right there is a fantastic thing. So you're giving that to all patients on antiplatelets because the risks are small, and you guys could fix your sodiums. You have the capability of getting your sodiums exactly where you want. So you're saying unless they're actually hyponatremic to start, you're giving all the antiplatelet patients DDAVP.
Right. There was a more recent study that questions the value of giving DDAVP. So even within our group, now there's some, we're going to revisit this, but right up till this point, we were doing it. The next time I talk to you, I'm probably going to tell you we're not going to do it.
That's the way of neurocritical care. I'm used to it.
Yeah.
All right. How about TXA? Any use for it in ICH patients?
So right now, the way things stand, TXA is not advisable in patients with spontaneous ICHs. There is at least one ongoing trial that will give us a better answer about whether we should do TXA or not. But for patients who have TBI, TXA crash 3s, in light of crash 3's results, I know one of the questions that your residents had asked was, how has this changed our practice? So I did reach out to our trauma neurosurgeons as well to give you a consensus answer. So specifically looking at just crash 3's data, so it's a very nicely conducted study. However, when we look at the timing of thrombotic complications in those patients, it wasn't very, they didn't do a subgroup analysis for which patients who were already at risk of developing thrombotic complications had developed those complications or not. Of course, at the outset, comparing patients who got TXA less than 3 hours or more than 3 hours, they said it was safe, that there weren't too many thrombotic complications. So for traumatic brain injury patients, it hasn't dramatically changed our practice just yet. A lot of these patients who benefited were those mild to moderate TBI patients, not the severe TBI patients anyway. So it hasn't changed what we're doing. We're still sort of doing it case by case. And to complete that cycle of, are we doing this in SAH patients? So we're doing Amicar for patients who have not had their aneurysm secured, again on a case by case basis. Specifically, we'll do this up to 4 to 5 hours before they undergo their angiogram. And for all of our subarachnoid hemorrhage patients, we're getting the angiogram done within, whether it's diagnostic or it's going to be both diagnostic therapeutic, within the first 24 hours. So if they present very close to, the angio suite is ready, and then we won't do the Amicar bolus and drip, but otherwise we'll do it.
All right, folks. So for folks that don't know, it's aminocaproic acid, and it is an antifibrinolytic agent, just like TXA.
Just like TXA.
All right. Well, unless you have any more comments on ICH, I would love to move to ischemic stroke.
No, I think we covered ICH well.
All right, fantastic. So in the ischemic stroke world, one question that we are now asking is, do you do a screen for LVO? And this is at your primary center, not the transfers. You're walking down by the ED. Are they going to be screening with some, screening scale to activate the neurosurgeons right away to get the CTA and CT perfusion? If you have a patient with just like left hand numbness, are you still doing the CTA? The chance of that being a large vessel stroke is basically nil. What's your protocol for trying to piece out which patients need screening for LVOs?
So right now, for New York City, the LAMS plus S is what our EMS crews are using on the front line. So we one of our centers, which is a thrombectomy capable center now at Mount Sinai Queen. So as it was becoming a thrombectomy capable center, it had moved from being a primary stroke center to thrombectomy capable. So how do you, it's very hard to say every single patient who comes in with, for example, left hand numbness, should that patient get a CT head CTA? Probably not. So thinking about refining or increasing the specificity of our scanning capability, we suggested if somebody had any visual field deficit, or they had a gaze preference, they had difficulty with their speech, and they had hemibody numbness or hemibody weakness. In those patients, absolutely, you should go ahead and suspect that they have a large vessel occlusion. If you look at the NIH stroke scale, now the NIH stroke scale, once you get used to doing it over and over again, you can potentially finish it in under 5 minutes or so. But for folks who are not used to doing the scale, it can take much longer, and you don't necessarily want to wait that much. So what I would recommend, if you're going to use the NIH stroke scale and you're facile with doing it, by all means, go ahead, do it, but have somebody else put in an order for a CT head CT angiogram. You can always cancel it. So that's one thing. So parallel processing is important. Two, if you're noticing that somebody has a gaze preference should alert you that, okay, it's going to potentially be a large vessel occlusion, aphasia, or hemibody signs, where you have hemibody numbness or hemibody weakness. One very important stroke subtype, which is much harder to diagnose, is a basilar occlusion. So these patients may sometimes just present with nausea, vomiting, and they're telling you nausea, vomiting, and they get misdiagnosed as having gastroenteritis, or let's screen them for COVID-19, right? So it's very important to test someone's balance, or just have them walk. So if you have them walk, particularly if there's no other focality, and you find that they're off balance, I think you should proceed with a CT head CTA. For our health system, we pretty much, our threshold is very low because we really don't want to miss large vessel occlusions, but fine-tuning it for your health system or your hospital, or knowing what the strengths of your hospital are, I think that's very important.
Now, I'm gonna put you on the spot here, and you could feel free to defer. But your neighbor comes in with all the signs of a large vessel occlusion, which is confirmed on CT angiogram. They have an MCA, and your interventional I don't know if it's radiology or neurosurgery at your place. They're standing next to you. The lab is ready. In this day and age, in your heart, is it better to give TPA or not to that patient?
Okay. That's a tough one. And in light of a recent Chinese study as well, I think if everything is a go, by the time, and your angio suite is ready, and this is specifically my opinion. This is not.
That's why I prefaced that way. Yep.
I would say just proceed with the thrombectomy.
Oh, I'm so happy to hear you say that. Yeah, I just don't understand. All right. Well, then that's fantastic. And obviously, if there's delay, or if it's going to be a while, if they have to come in from home, you're going to give the TPA in that case. But
there's one caveat, though, I should mention that having spoken to some of our interventional colleagues, they do mention that it becomes easier to get the clot out after someone's received TPA, because it's not as dense, it's not as hard. So it does make the procedure a little bit easier. That's one. Two, on the other end, on the other spectrum, so going back to that patient I mentioned that had, like an ICA occlusion. Now, are you going to acutely stent this patient or not? Or you find that they've got this, really tight MCA occlusion. Are you going to do an intracranial stent no matter how much you try to remove a clot? Because there's an unstable plaque, it just keeps forming back. So when we're thinking about hyperacute stenting in those patients, again, that's a patient population you've got to be very careful about TPA in. And there is no good study that guides us. We're collecting our own data to see the risk of hemorrhagic transformation, because we end up using antiplatelet drips in these patients, like integralin or more recently cangrelor. So if you're going to use medications like that and they're going to be on dual antiplatelets right after getting TPA, the risk of hemorrhagic transformation is a little bit higher.
All right, fantastic. Let's move on to a topic that is my favorite topic in the whole wide world. And since you're an EMCrit listener, you know what that is, which is airway. And
yes.
My first question in the airway realm is you are at your hub center and you've gotten a transfer call and they're telling you about a patient who's still rousable to voice, but they're like a little drowsy. And they're like, I want to intubate. Now, me as a receiver, I would always prefer if the patient could come without being intubated. First of all, it allows my assessment to be better. The medics we send for transfers are amazing. If the patient decompensated, they could handle the intubation. But you have someone on the other end of the line saying, nah, I really want to intubate. And you're getting the sense that they want to intubate because they want to intubate. Who needs to be intubated in neuro emergencies? Let's talk specifically about strokes, whether ischemic or hemorrhagic. And how do you make that evaluation? And is your threshold low, high? Let's hear about that a little bit.
That is absolutely fantastic. So let me first start with one of the key principles in all of neurocritical care. So you recognize the primary injury and you want to prevent secondary neurological injury. By secondary neurological injury, cerebral edema, herniation, seizures, etc. So you really, really want to prevent secondary neurological injury because that's the paradigm that's going to help your patient embark on this perfect trajectory towards recovery. Having said that, how do you decide who needs to be intubated? So there are two things that I always teach our residents and fellows about. Say, what is your anticipated trajectory for this patient? So they're looking great right now, but what is going to happen to them downstream? Are you going to be subjecting this patient to an inter-hospital transfer? I'll take the example of a subarachnoid hemorrhage patient. Very classic. We do a lot of these SAH transfers, and we get a call. The patient's a little lethargic. They're disoriented, and they're complaining of this really bad headache. I'll ask for, okay, let's pretend it's one of those sites that doesn't have a PACS system that we can see the images for. I'm suspecting, when they're telling me the story, I'm already suspecting, okay, this person's going to have hydrocephalus on their head CT, and they do not have neurosurgery to place an EVD prior to this patient undergoing inter-hospital transfer. So what am I going to advise them to do? So I'll take a look at that head CT. I see, yes, this person has a modified Fisher grade 3 subarachnoid hemorrhage. There's thick blood. There's no intraventricular hemorrhage, but this person has obstructive hydrocephalus because there's some blood in the fourth ventricle. So what I'm going to advise them to do is maintain all ICB precautions, and we'll talk about what that'll look like, and go ahead and intubate prior to transfer, and also give pre-medications with mannitol. So 1 gram per kg of mannitol, chase that with a liter or so of a crystalloid solution, whether it's normal saline or Plasma-Lyte, whatever is available, but an isotonic crystalloid solution, and transporting this patient with the head of the bed at 30 degrees throughout, hyperventilating the patient for a PCO2 goal of 30 to 35. Another key thing to keep in mind, so this patient that I'm describing to you, I know that this person is potentially going to worsen as they're undergoing that inter-hospital transfer, because what they really need, one of their life-saving interventions, which is time sensitive, is going to be that EVD placement. And till I can't get them to that EVD placement, how do we bridge them? So all those things to prevent secondary neurological injury, I'm going to advise, go ahead and intubate. So that depends on the anticipated trajectory of that patient's clinical course. The second kind of patient is who's already telling you that they need to get intubated. So how do you identify that patient? So a GCS is a good guide. It's a quick and dirty guide to tell you who's not protecting their airway. So GCS of 8 or less is going to be a good guide. And then again, depending upon the underlying disease process. So like we mentioned, acute ischemic stroke, particularly basilar patients who have a basilar occlusion, even if they haven't slipped into a coma or they're not locked in, the whole purpose of getting them through this process is to prevent them from completing their stroke. So that's going to be very important. However, thinking about hemodynamics around the airway is extremely important. So you want to prevent secondary neurological injury, whether it's hematoma expansion in ICH, whether it's re-rupture of an aneurysm in subarachnoid hemorrhage, whether it's completion of an infarct in a patient with large vessel occlusion. Having both kinds of medications, both antihypertensive drips and pressors ready to go, I think it's extremely important. And then letting your team know, verbalizing this even before you start securing this person's airway, because most of these airways are going to be urgent. They're not going to be emergent, like you have to get the airway in now. So prepare your patient for success. Just letting people know what your blood pressure target is going to be. Just going over our blood pressure target again for SAHs, unsecured aneurysms, less than 140, ICHs, less than 140, but maintain it more than 100. For TBIs, again, less than 140. For patients you're going to give TPA to, do less than, so before you give TPA, less than 185 over 110. But if you can't remember both of those numbers, just do less than 180 over 105, which is your post-TPA number. And make sure that you don't let these patients become too hypotensive either. We talk about permissive hypertension. Otherwise, their collaterals are going to give out. You haven't given them the opportunity to undergo their thrombectomy, and then they complete their stroke. So you don't want any of those. And a couple of other pre-medications to keep in mind when you're suspecting elevated ICP. So fentanyl. I think fentanyl as a sympatholytic agent is definitely good. Do about 2 to 5 micrograms per kg. That's a good dose. Lidocaine, more controversial. I was using lidocaine. I want to say I was using it in all of my airways where I was suspecting ICP crisis previously. The more I think about it, I mean, what I'm getting with fentanyl, that sympatholytic activity with fentanyl, then I don't necessarily need that from lidocaine. So I might choose to just proceed without giving lidocaine. And throughout, right till the point you're ready to intubate this patient, keeping that patient's head of the bed at 30. I think that's important. If your patient was already on high flow nasal cannula, then that's what I'm going to use for pre-oxygenating, as well as up-titrating the flow so that you can hyperventilate. So you've already hyperventilated with high flow, then you can take that off. And then I'm a huge fan of apneic oxygenation. So I'll leave that nasal cannula in, particularly if it's not going to interfere with mask seal. And then with prevents data, I know it was also very controversial, giving a few tidal volume breaths. Should you do that? Shouldn't you do that till your paralytic is kicking in? I've been doing that. I've been doing that for a few years now, because I don't want my patient to hypoventilate, not necessarily for oxygenation, but we'll do few tidal volume breaths till, if it sucks, then you'll wait for about 30 seconds or so. If it's raw, you're waiting a little bit longer, about 45 seconds or so. But that's pretty much it.
Yeah, you've pretty much detailed exactly how I would go about this. And there's a podcast for you folks if you want to listen to it. With the only difference being, and it's certainly, there's nothing wrong with either direction, but why are you choosing mannitol in these patients rather than hypertonic saline for the
I should have said mannitol or hypertonic saline, whatever is available. So you don't want your team on the front line to feel this sense of panic, like, I don't have this medication. What am I going to do? Well, when you look at the most recent guideline statement from the Neurocritical Care Society on cerebral edema management, for most disease processes that we've discussed, SAH, ICH, it's pretty comparable. Yes, after you have reached the destination, whether it's an ICU, whether it's the OR, hypertonic saline does have a better, long-lasting effect on this ICP, on lowering the ICP. Plus, it has other benefits as well, including maybe some effect on the endothelial glycocalyx and helping restore some of that blood-brain barrier, some anti-inflammatory properties. Having said that, though, you've got to be practical. Whatever you have, choose what you can do quickly enough, because time is brain.
I love it. All right. Well, then, since we're on that topic, let's pivot to that. So osmotic therapy for ICP elevations. Let's say the patient already has an EVD in, so you actually have a spike. They spiked to 28 on their ICP. You have all three in front of you. The nurses have laid it out like a deck of cards. You have mannitol, 3%, and 23.4%. What do you choose? When would you choose each of these over any of the others?
Okay, so first I'll check if that EVD is working or not. Make sure that there isn't a clot. And if there is, then have somebody else on your team, page neurosurgery to come declot that EVD. So that's one. Two, in terms of any of these, if I have 23.4% available, I'm going to go with 23.4%. It acts very quickly and you get a more sustained effect. Even in head-to-head comparisons, albeit the quality of this literature is not fantastic. These are small studies. A lot of them are retrospective studies. But having said that, despite not having great quality evidence, we know that head-to-head, 23.4% is better than mannitol in a patient with ICH, in a patient with SAH and obstructive hydrocephalus, even in patients with TBI. So I'm going to go with 23.4%. I should mention access. So access-wise, for 23.4%, central venous access, now you don't necessarily need to have a central line in place. So what we've been doing within our health system, we'll do a direct femoral stick. We'll make sure that we have pressors ready at the bedside. Typically, we'll have levo ready at the bedside. We're choosing levo because it's more balanced. At the same time, some patients do tend to develop bradycardia very transiently, but they develop bradycardia as you're injecting 23.4%. So we don't necessarily want to use neo because of the reflex bradycardia. So we'll have levo ready at the bedside, but prime the line because you want to avoid using push dose pressors if you can, to maintain a more sort of steady state and you're not jumping in and out of different ranges. So we'll prime the line. I'll typically have the nurses, start that levo at 1 or 2 mics just to have the line primed, give about 5 cc's of that 23.4% by way of a direct femoral vein stick, see what happens to the heart rate and blood pressure. If they've tolerated it fine, then I'm just going to go ahead and give the rest of it. Now, what's been described better in literature is about, okay, you give it over 10 minutes, etc. But when a patient is actively herniating, I'm not waiting 10 minutes. I'm just going to be very careful, again, going back to that principle of preventing secondary neurological injury as you're trying to treat, one problem. So I think those would be the two important things.
Got it. All right. I think we have time for one last topic. We'll hit it quickly, and it's status epilepticus. And 2 questions you can answer in whichever order you like, which is, my paradigm is try your initial benzodiazepines, and then if they're still not coming out within about 5 minutes, move immediately to intubation and general anesthetic. And whether you buy that or not, what general anesthetic are you choosing once you do get there, whichever route you take? And then which second line agent are you choosing? Is it Keppra? Is it fosphenytoin? And if you do choose Keppra, what dose? With the new literature that just came out. And there's a lot there. I'm sorry. You take it away.
This is great. So we'll cover all of status epilepticus now. How much time do we have?
We have 12 minutes to cover all of status epilepticus.
So I can cover status epilepticus. Yeah. Okay. So let me preface this by, if EEG was as widely and easily available as EKG, every patient would be getting EEG leads on. I mean, it's one of those continuous, non-invasive neurophysiological monitoring technologies. It's phenomenal, right? However, we don't live in that kind of world. It's very labor intensive. It requires a lot of resources. So a lot of our places, despite even places that have 24/7 EEG tech availability, even their delay from time to request to time to hook up is about 4 hours. So having said that, for the clinicians who are diagnosing convulsive status epilepticus, it's easy because you can see it happening, and you're starting with your benzodiazepine. About 25% of your patients are going to then go into non-convulsive status. How are we going to know that they've gone into non-convulsive status? It's very hard to diagnose it because your patients may either just slip into a coma, so their GCS is going to be 8 or less, or they're going to have very subtle clinical signs like a little twitching of the angle of the mouth, or a little hippus reaction of their pupil, or a twitching of their thumb. So it's very hard to diagnose which patients have gone into non-convulsive status epilepticus without EEG. And 2, if your patient has just gone into a prolonged post-ictal state, then how do you tease that out? So some of our status management, and I mean our as in the entire field status management, is driven by lack of objective data. If somebody does not have clinical seizures and you don't have EEG data, then you're going to do what you think is the best for the patient because you're right there at that bedside. So in terms of ramping it up, so for our NEMAT protocol, again, it's multidisciplinary. It went through several rounds of revisions. We had our epileptologists and everybody, neurointensivists, everyone weigh in on this. So what we did was adopted that timeline from there are a couple of societies that published their guideline statement, including the Neurocritical Care Society, and looking at 0 to 5 minutes, exactly what you described, Scott, and then we will still go with our second line agent rather than proceeding directly with intubation. However, if the clinical suspicion for this person, for whatever reason, they have a mass lesion, or they were just in the hospital because they had undergone, their subarachnoid hemorrhage treatment and they had seizures while they were here. Now they didn't have insurance, they didn't take their medication. So depending upon your clinical suspicion as well, if you think this person is really in that 25% or so that is going to go into non-convulsive status, if you don't break it by way of a general anesthetic, by all means, proceed with intubation. But the second line agent in terms of the choice with ESET, we know, looking at Keppra, valproic acid, Dilantin, I mean, it was a pretty well-conducted study, but it also lacks this EEG data. So they do not describe, when they say seizure termination, it means clinical seizure termination. But does it mean that, your patient is not in non-convulsive status or not having non-convulsive seizures? Probably not. So Keppra, we realized after this particular study, yes, we were definitely underdosing. And across the board, I think we had all been underdosing it. So we are doing 60 milligrams per kg. Dilantin, valproic acid, those doses were pretty comparable, the 20 milligrams per kg for Dilantin or fosphenytoin. Then for valproic acid, 40 milligrams per kg. Which agent are you going to choose? So based on ESET, there's no difference between these three. Depending upon the underlying comorbidities, I think that is very important. So if somebody has hepatorenal dysfunction, or they're a cirrhotic, or they've come in with fulminant hepatic failure, you're not going to give them valproic acid or Dilantin. You'd rather give them Keppra. So just thinking about the milieu or the picture that this person has come in with, and to prevent, again, secondary neurological injury by way of preventing any other systemic injury as well, I think that paradigm still holds true. And then in terms of the drips.
Before you get there, Neha, for these guys who really just want as concrete as possible, based on what you just said, is there any status epilepticus patient who shouldn't, for the emergency docs listening, just get Keppra 60 per kg?
An end-stage renal disease patient who's on hemodialysis.
What would you give them?
So you want to give them about, give them 20 or 30 milligrams per kg. So give them a lower dose.
Choose Keppra. So it's always Keppra with a dose reduction in renal failure until the neurologists get there, and then they might make other choices. But for these guys listening, you'll never go wrong with Keppra. Dose it at 60 for patients without renal failure, and go half of that for patients with renal failure.
Yeah, go half of that for patients with renal failure. If you don't have Keppra, go with Dilantin. It's always a safe choice. But just make sure that you're running it. If you're going to have fosphenytoin, run it at less than 150 milligrams per minute. If you're giving Dilantin, then run the drip at or your infusion at less than 50 milligrams per minute. Otherwise, these patients can develop profound bradycardia or complete heart blocks. For the general anesthetic dosing. So how do we choose? So our go-to is a Versed drip. We're going to do 0.2 milligrams per kg, initial bolus. Then start your drip at 0.2 milligrams per kg per hour. Again, going back to, you need your pressors ready at the bedside because your patient is going to become hypotensive. So keep that ready. If you have your patient connected to EEG, then every 2 to 5 minutes, keep ramping up. Go with 0.2 milligrams per kg bolus, increase the drip to 0.2 milligrams per kg per hour. You can potentially go all the way up to 2.9 milligrams per kg per hour. It's a massive dose. You could totally go all the way up to that. That is safe. That's what's been recommended. However, there's an important change that we made to our protocol: ketamine. So ketamine 1 milligram per kg as an initial bolus, and then starting the drip all the way up to, you can ramp it up again every 2 to 5 minutes, all the way up to 7 milligrams per kg per hour. Having said that, though, when are we introducing ketamine? The dose previously we'd go up to 2 milligrams per kg per hour on Versed, then introduce ketamine. However, we're discovering this, and there's some literature to now also suggest that maybe ketamine should be moved more upstream. So by the time we're reaching 1 milligram per kg per hour, 0.9, we're introducing ketamine already. The advantages of ketamine, it's going to cause some externalization of your benzodiazepine receptors. It's going to be a benzo-sparing agent. It's more hemodynamically stable as compared to causing profound hypotension with Versed. And a quick caveat about patients who have cirrhosis. So when those cirrhotics are coming in with status epilepticus, make sure that you're stuck between a rock and a hard place, because benzos are bad, propofol is bad, any GABAergic agents are bad, but you've got to terminate their status and eliminate whatever the other important paradigm in status treatment. Status is a symptom. The status epilepticus is a symptom. Treat the symptom, but keep looking for that underlying cause. So for this cirrhotic, we'd opt for propofol as opposed to Versed. Because in these patients, even after you turn off that Versed drip, these Versed metabolites are going to linger on, particularly 5-hydroxymidazolam. It's going to linger on for a few days to weeks. So you have this prolonged postictal state in somebody who has this super refractory status epilepticus. They're not waking up, they're in a coma, but some of it is also going to be iatrogenic then.
Oh my God, you are a trooper. You've just done greater than an hour of continuous grilling. You did not let your composure drop for 1 millisecond. That was absolutely astoundingly good. Folks, I think you should unmute and give a round of applause to our amazing neurocritical care colleague.
Oh, thank you. Thank you so much, guys.
Oh man, we can't thank you enough. You have a wonderful day and know you've educated many of us. This has been fantastic.
Thank you again. Thank you for the opportunity. Everyone stay safe and healthy.